Welcome to the Advantage Insights podcast. My name is Carol Wellaway, and I'm the founder and CEO of Advantage HCS, a healthcare consulting company. Our team is made up of passionate healthcare providers, all on a mission to transform healthcare. Through our Insights podcast, our team, as well as occasional special guests, will tackle today's biggest challenges within the healthcare industry. So, let's get started. Hello, everyone. I am Dr. Carol Wellaway. I'm here with Advantage Insights. And today we have an awesome group of our consultants here with a very interesting topic. So I'll let everybody introduce themselves. We'll start with Dr. J.
Hey everyone, I'm Dr. Allison Jordan. I am a physician, board certified in internal medicine, psychiatry, hospice and palliative medicine, culinary medicine, and health and wellness coaching. Excited to be here tonight.
I don't want to follow that. I'm just playing. Hi everyone, my name is Nicole Andrews, board certified emergency medicine physician hailing from Houston, Texas.
Hello, everybody. My name is Dr. Susan, and I am a head and neck surgeon practicing in Arizona. And I am board certified in otolaryngology and also lifestyle medicine.
Hi, my name is Aaron Valeroy. I am the advisor for data analytics. My expertise is really just taking the data that you're already capturing within your health system and turning it into business insights. So nice to be here.
Hello, everyone. I am Melanie Kachanji, board certified urologist practicing in Tulsa, Oklahoma.
So, Dr. Kachanji, why don't you get us started? I know you read this really interesting article and wanted to talk about it.
Yes. So this article, it came out in the New York Times. And when I saw this article, it bothered me, or it triggered me on a lot of levels. I thought about how this plays into burnout, how this plays into how we practice medicine in terms of the art of medicine. We always talk about medicine being an art and a science, and I think we all learned the science in school. But I think part of that art of medicine is how we show up. And if we're not allowed to show up as who we are, I think that's an issue. And who defines how we should show up, I think for the most part has been defined by what medicine always looked like 80, 90, 100 years ago. And now we have people like women that were not in medicine at all, were not represented. So should we still wear suits and pants or skirts and pants because men wore suits and pants when they showed up to work? So how do we show up and be comfortable being women, being feminine, be comfortable being people of color? And just the fact that we still cannot comfortably show up as ourselves, does that contribute to burnout? Does that impact the art of practicing medicine? So this really bothered me, especially I think there were a couple of situations during interview season a couple of years ago where a resident didn't get in because of her social media profile did not represent what a physician should look like. So I figured, this is something that we should all be aware of as physicians. But then as physicians, how do we make it better? How do we show up? How do we create room to show up as our authentic selves? We should be held to the standard of the knowledge, the science, but to really practice the art, we should be able to show up as who we are and be accepted.
Great points. Great points. Yeah, and something that I don't think we always think about in medicine. And to your point, so much has changed from when medicine started. And I think there does probably need to be some type of acknowledgement of that, and the fact that different people are practicing and what does that mean.
to the practice of medicine, to patient care, to practitioners. What do you all think?
I would actually like to hear from the providers around if you feel COVID had an impact on forcing that change that may have never happened if healthcare wasn't thrust into a situation that we've never been in before. I know I can speak for myself, which is data analytics. I know definitely it changed how I would say how data analytics is looked at and how we perform. Obviously, a lot of my colleagues are remote now, so I'd be very curious to hear more about, like, from the provider side. Do you think COVID may have helped push those boundaries and say, hey, listen, we may have done this 100 years ago, but telemedicine may be more prominent now, and allowing physicians to be a little bit more casual, and really just changing with the times. So I'm really curious to get your feedback if you feel like that COVID had any impact to help move this along.
That's a really good question. I think Dr. Andrews, you had your hand up.
I think to answer your question, yes and no, Aaron. I would say I think that it forced us to change the look of medicine within specialties. I think that it forced, and this is no shade to my primary care providers, but I think it forced primary care in a different light. It forced ER to see OB in a different light. It forced OB to see, ENT in a different light. We all kind of saw our roles very different. I don't know that there was a casualness that was allowed, if that makes sense. At least not on my part. I felt like during the pandemic, I won't say that I was under a microscope, but I felt like I didn't have time to be me. There was no time for me to think. There was no time for self. Unfortunately, like during that time was a great life experience. Like I had my second kid a week before the week of the shutdown, and then was thrust back into the emergency room doing things that shall go. Those are experiences that I don't really want to relive, but those things didn't allow for me to be me. I think that was the first time that I considered, and we all talked about, I talked to Carol about it, but I strongly considered walking away because I was just so done. For more reasons than one, not because at that time was just unsurmountable. Like I couldn't get over that mountain, if that makes sense.
Yeah, that makes a lot of sense. Well, thanks for sharing those. Thanks for sharing those experiences, because I think that helps me understand what the physicians were going through. Like you said, it's hard to know exactly what everyone's feeling. You know what you're feeling through that, but to hear from you makes a lot of sense that there really was no time during COVID to be relaxed at all. So that makes a lot of sense.
So I like this COVID question actually, because through COVID, my dress code changed. So when we talk about professionalism, especially as providers, oftentimes it's broken down into our behavior and also our appearance, how we look and how we sound, especially as people who don't fit the traditional framework of medicine, when, medicine was sort of in its maybe glory days, some people will say. Many of us look different, women, many of us sound different because we come from different cultures. We carry different vernaculars with us in the way we speak. So I think your question is so brilliant because my look changed and COVID really instigated that. I'm a very casual person by nature. I don't like to wear heels. I don't like to dress up. But throughout my medical career, have been very, I wouldn't say the word stressed, but very it's something that has weighed on me in terms of how am I being perceived, knowing that I'm not somebody who loves to wear a suit and loves to wear a dress or loves to wear skirts. When COVID hit, and at that time, actually, I bought some clothes, I bought some slacks, and I was really kind of like, I gotta look this way because my partner at the time, the practice I was at, I love her. She's fantastic. And she's kind of one of these women that makes you feel like I should be doing better. My hair is a mess. This one has 3 kids and she looks amazing. So, she comes to work dressed up, her nice heels, and she just looks gorgeous. And I'm like, I can't keep up. So when COVID hit, I remember saying, oh, well, now I need to wear scrubs because I don't want my nice clothes to get exposed to COVID. And, it's just safer. And I'm going to be wearing all kinds of gowns. It's safer. And then safer became, oh, it's much more comfortable. And then much more comfortable became, this is a lifestyle. This is a lifestyle. And to this day, I still wear my scrubs in clinic. And you know what? It was funny. I was washing some clothes and organizing my scrubs and everything for the week. And I looked at these clothes that I'd bought for COVID, when I don't even think I can fit them anymore. But I looked at all these like slacks and things that I bought and I was just like, I haven't worn these in forever. And you know what? I don't care because with COVID, I think a lot of people got comfortable with seeing physicians in scrubs, especially in the clinic space. And so now it's expected. So I think COVID really pushed, at least in terms of in the outpatient setting, does wearing scrubs look professional? It allowed many patients to see us still do what we do, still dressed in scrubs, and we're still knowledgeable. We're still giving you good care. So I'm not turning back is a moral of the story.
Well, and I have to say, I love the statement you made about you didn't even know you were uncomfortable until you started wearing your scrubs. You're like, hey, wait, I'm comfortable. And I have to tell you, I had the same thing happen to me. I am just like you. I don't like dressing up in suits and ties, and it's just constrictive. And so when I started working remote and working from home, I find myself, in t-shirts and gym shorts. Next thing I realize is that I feel better doing the work that I'm doing. And I love that we have this topic tonight because I do really think it's very important about, we're all about diversity and inclusion, yet there's this strict standard on appearance and how you articulate things. And I do think there's a certain need of, you need to be able to speak intelligently on the topics that you are the master of. However, appearance and look, I feel like should be custom to who you are. Ultimately, because I say that because of this, I feel like when I'm comfortable wearing things that fit who I am, I'm confident. I feel better, which again, I think is why I don't feel burnout. I feel like this is what I want to do. I am me. So yeah, I'd be very curious to hear it from you guys as well, because I think there's a big difference between me and obviously providers, because you are in the hospitals, you're patient facing. So for me, there's nobody being like, well, Aaron, you just don't look professional. I don't get that. But you guys being patient facing and in the C-suite's eyes, that's tough, because I feel like maybe they are the ones driving this standard of appearance. So yeah, thank you for bringing that up.
I think that's a really good point. I know when Dr. Kachanji shared this with us, that was one of my first thoughts was, okay, we're all in this space, not just in medicine, but in career industries as it is it's important to be your authentic self. It's important to have psychological safety when you're at the workplace for all the reasons that Aaron just described. So if that is the case, then what does that mean in medicine as far as professionalism? And the other thing is, who gets to decide that? Is it the medical body? Is it the individual physician, nurse practitioner, PA? Is it the patient? And who does it matter to? I think Dr. Susan's point about patients got to see us in scrubs more often. I'm with you. I dressed up every day in the hospital to see patients. I think it was usually okay if you're on call or working nights, you could wear scrubs. And so that was like the one good thing is I get to wear scrubs. But I've pretty much worn scrubs every day working clinically since COVID. And it's nice. You don't have to think about anything. You're not worried about, am I falling apart toward the end of the day? I'm tired. Is everything still tucked in? Like, it's just nice to not worry about that. I agree. And I think that's an important point is, does anybody care about that? And who does? And why? If it's off-putting to people, why might that be? I mean, what, 4 of us trained on an island in Galveston, where people would come on the weekends in swim shorts, swim trunks for sure. I remember an attending coming in and thinking, oh my. Now, in my mind, like, that's not really what a doctor is supposed to look like, but he's the attending and it's time to round, so let's go. I don't think that would have flown when I was in Michigan or in Baltimore. Like, that just wasn't their vibe. But I mean, obviously, he felt very comfortable. I don't think they would have allowed any of us students or residents to do that either. But he was obviously very comfortable. He was on his way to his surfboard. This is just a stop on the way. And is there a problem with that? I don't know.
I think when we say who decides what professionalism looks like, there's 2 answers. I think the provider and I think the patient. And the reason I say that is most of us are very familiar with the term code switching. And if you're not, what that means is that I speak one way when I'm in a room full of a certain demographic. And when I move to the next room, my vernacular, my my accent, my colloquialisms will change depending on who I'm with. And I am your quintessential code switcher. I can do it on a dime. Most of the time, I don't even realize that I've done it, right? And when I know it's happened is when someone from the previous room follows me into the next one and they do one of these.
Who are you?
Right. Right. It's like, who, and so I think that when I walk into a room with a patient, if it is, I'm in South Texas. So if it's little Meemaw from Polk County, she does not want to hear me speak the way that I would if I was talking to someone from the south side of Houston. I got a code switch. But I bet you I'm going to make each one of them feel comfortable. Am I comfortable? It probably lies somewhere in between, right? The true self of who I am. The other part is it's really difficult to define what that is when you work for a large entity. Because in your contractual agreement, that entity gets to decide what you look like, what that professionalism looks like. I can't speak for the other ladies, but I know that when we were in med school, I relaxed my hair to keep my hair straight because that is what professionalism was deemed as then. Now I don't. You're going to get this. I don't know what it looked like. I barely look in the mirror to comb it. So, I think that in some aspects, society and medicine as a whole has relaxed what they deem professionalism to be across the board, because previously the demographic was not those of us that are sitting in this room for one reason or another. But now the tides have shifted. And I think that by implementing things like DEI and being aware of those social constructs, it allows for the potential for people to feel more comfortable in their true selves when they're rendering medicine. Because the truth is that when your physician is more comfortable and your patient is comfortable with the physician that's rendering care, we have less incidents of malpractice, negligence, or misunderstanding. Patients are less likely to sue those providers that they feel comfortable and they have confidence in. Well, it needs to be somebody that can speak those colloquialisms, that can speak that accent, that can understand, what that Gullah Geechee, culture looks like, what that South Louisiana thing looks like, why you put potato salad in your gumbo and not rice, because I don't get it, right? I have to be able to move in those spaces, and we have to allow in medicine for us to grow and to understand that not every physician is going to look like Nikki, and Nikki is not going to look like Susan, and Susan's not going to look like Carol, and Carol is not going to look like Dr. J, but all of us render great care when we are able to be who we were designed to be so that we can be comfortable. Like, this is still a mask, right? I want to make sure that I'm presentable for the camera. I want to make sure that people can understand what I'm saying, because if I let my true accent slip, I can guarantee you my friends that have known me for 20 years are going to be like, what did you say? I don't know. I hope that with this and these conversations, we can continue to open those doors. Because right now, society seems like they want to close them for whatever reason, but we need to continue to open them to allow room for patients to get better care. And that's by making sure that their providers get better care across the board.
So, really interesting comments, Nikki. I think what I would say to that is, when you talk about the choice of words when you walk into a room, I really think that's emotional intelligence. You recognize the patient, you read the room, you know how to connect. That is emotional intelligence. But when you have to walk in with a suit and speak exactly the same way to every single patient, you would lose a lot of patients along the way, because they're like, he walked in with a suit, by external standards, looking very professional, sounding very professional, but oh my God, my grandma from Cameroon is like, who is this? Or a grandma from South Texas is like, que pasa, what just happened, right? But you with emotional intelligence, with your curly hair that may not be considered professional, walked in and say, ¿Cómo estás? That's all the Spanish I know, but you just made her comfortable by making an effort to meet her where she is. But I think when we really look at professionalism, a lot of times we are looking at external presentation and then the off-putting behavior, which is not standard to physicians, right? But for the most part, when you walk into the room, it's they have dreadlocks. There must be a nurse or there must be physical therapy. They can't be a doctor. That's the challenge, because that's how some of our residents or future physicians are getting left out when they show up for interviews.
Right. And even with that voice, but it starts there, right? We can have the emotional intelligence and we've got the skin in the game to know how to move in those spaces. But those people who have come behind us, like when I go back to Prairie View and speak, those students have not been in those boardrooms. So they don't have the intelligence to switch. So when they hear that accent, when they hear those words, it's immediate. Nope, they're not professional. People who are professional would never speak that way. Right? It's not just the look, but it's also the sound. And that's what I was trying to get across. I definitely agree. As soon as people see dreadlocks, the first thing that they're going to say is no. Same thing for people who, my hair is curly, but if yours is kinky and you decide not to straighten it, is that deemed unprofessional? My sister has dreadlocks and was told that she needed to comb her hair out because it didn't look professional in a boardroom. Or that she needed to not use certain vernacular because it didn't sound good. That's what I mean when I say, like, making those code switches. That's where it comes from. Yes, emotional intelligence, because I can understand that the person that's looking in front of me doesn't want to hear buttoned up, super proper, I grew up in River Oaks, Texas, Nicole. They're not going to understand that. But when I walk into the boardroom, that's exactly who I have to be. That's not me. I didn't grow up in River Oaks. I don't even know how to get in there.
I'm sure you do, Nikki. But that's your emotional intelligence serving you. But unfortunately, a lot of the people behind us, I think I'm seeing it increasingly where people are, it's like, oh, I don't know, he really didn't look like a doctor. And I'm like, what do you mean? We shouldn't rank that candidate because they didn't, I'm not sure they look like a doctor outside of work. And I'm like, what does that even mean?
Mhm. And do
I
you
want to.
need to look like a doctor outside of work? I guess that's another thing.
Yes, like a resident was like, oh, no, if you see him outside, you can't think he's a physician. And I'm like, what does that even mean?
I
Why would I
mean,
want somebody else to know what I do?
Well, that's what I was going to say. Maybe that's on purpose. Don't
yeah,
dress
I
like a
remember
And
analyst
it.
outside.
we never told people, even when we were in med school, we're working in healthcare. Are y'all
I
in
would tell them
nursing
now,
school?
you better be dying in my feet. I'm just playing.
Because I've
I
been
want
told
to add
many.
to that. I want to add to that as somebody who has locks and kind of this is actually something very um, dear to me because of the hair journey that I went through, much like Nicole. So I grew up, I mean, as all of us, my mom started relaxing my hair from birth. I, until my 20s, had no idea what my natural hair looked like. And we were in, I think it was our PhD class. I went to med school with some of these ladies. And I remember we learned about the toxic nature of hair relaxer. And I'd never been confronted with it before. And when I thought about it, I said, well, why am I putting this cancer causing agent in my hair to fit somebody else's opinion of me, to make myself more palatable? And so in med school was when I finally, in the community we call it big chop. You cut off all your relaxed hair and you let it grow. And it was very much a statement to finding out my true self. Well, when I got to fourth year and I was applying to ENT, which, you know, is a very competitive field, I became very terrified that my afro would keep me from the field. So I permed my hair. I hadn't permed my hair in 3 years. And I permed my hair. And I remember looking in the mirror and I mourned it. I had fallen in love with my afro. I'd fallen in love with my hair texture. And I felt defeated. I kind of get a little emotional thinking about it because when I go back to that moment, I went from feeling empowered to disempowered just to do something that I wanted to do. And so I went on my interviews and, you know, they did fine. But when I was done, I said, would these people still want me? Would they still rank me? Would they still accept me if I had left my hair the same way? And so then after I ranked and, you know, I knew I was going somewhere, I cut my hair again. I big chopped yet again. And, you know, the second go round with my hair, it just didn't feel like the first time because there was a psychological part of myself that said, you gave up. You gave up on yourself. You let people's opinion mean more than your own opinion of yourself. And then through my second sort of big chop and being in residency, my locks became a way to reclaim that part of myself. When I graduated, now mind you, I still didn't have the confidence to do it as a resident. But when I graduated and finished my fellowship and I was showing up to work, my hair was not me. I felt like I wanted to defy what people thought of me based off of my hair. And even though my hair was natural, I'd always wanted locks. And, you know, it was for, you know, not just for styling, but really for ease. And I remember sitting down before trying to go through the process of getting locks and getting twists in and feeling that same fear and that same judgment. And this time I said, not going to happen. I felt defeated in a way that stayed with me for a long time. And this time I said, it's not going to happen. And so I did locks and I got the judgment. Until this day, my locks are long. Sometimes when I haven't done my retwist, I look Rastafarian and I boldly go into rooms. And I do so because I know, yes, you may judge me in the snap moment when you see my hair. Sometimes my hair isn't up, sometimes it's down. But the minute I start talking, you cannot defy my expertise. The minute I start talking, I'm able to show you and tell you I know what's going on. And so that when you brought up the locks, I was like, oh, no, I wasn't going to do it. But it just,
Okay.
I went there because, recently in social media, there was a push by some of our colleagues in the dermatology world to get the board of dermatology to end a lot of these DEI initiatives. And we know DEI is so heavily politicized, but we need to make people understand that we are people. Diversity is happening around us. More and more, we've got a diverse society, and we have to make room. And when you deny somebody something that others are afforded, it's not just a flippant decision. It affects people psychologically. It sticks with them. And this is the kind of thing that can harm somebody emotionally, harm someone's confidence, set in perceptions of themselves that they have a hard time getting rid of, when we can make room for people and diminish some of these things. So thank you for bringing that up. Sorry, I got a touch emotional, but it just goes to show how important it is.
Well, Susan, thank you so much for sharing that, because I noticed you got really emotional, but thank you. So then what do you tell a mentee if you were mentoring a student that was going to med school and showed up with Afro? And they come up with the same fear you just described? What do you tell them?
I told my mentee to continue to be themselves. I did. That is what I said. I have one who just graduated from a Harry, and that was something we talked about. She was terrified, and she had locks. And I told her about Susan relaxing her hair our last year in med school. And I remember that. And that was one of the reasons I stopped relaxing my hair. And I told her, the only thing you can do is make sure that you are neat and that you look like you're coming to talk about business. So if you want locks, make sure they're twisted. You got a fresh twist. They are pristine. And if you don't want to do it, fine. Make sure you brush down your edges a little bit. Make sure that you are the neatest version of you, and then use your mouth to kick open that door.
And that's exactly what I would say. The level of regret that I carried and the disappointment that I carried wasn't worth it. Wasn't worth it. Any space that didn't want me because of how I looked and not because of my knowledge and my resume didn't deserve me. I would, if I had the opportunity to go back, and I've thought about this so many times, I would have never done it.
But I also think that comes from a lack of understanding from the people around us. We didn't have that support system back then. It was just us, and we were babies. God, I shudder when I think about how long ago that was. But we were babies, and no one was there. I remember looking at Susan like, "Girl, we not gonna relax it. Okay, okay. Well, what you do, okay. We relaxing. We not, because I didn't know either. No clue. And so you're looking to the left, looking to the right, and we were blessed enough to have enough people around us that look like us, but I worry about the ones who don't, and you don't have anybody to your left or your right, or to show you that it's okay to be you, as long as you're not doing it to the detriment of the person next to you. We just didn't have that support system, and I think that that's what we're missing. We need it across the board, whether you are in data analytics, whether you're in graphic design, whether you're in marketing, or wherever. We need people like yourself who went through it and knows that it's not worth it on the next step, to say, listen, I've been there, I've seen it, I know what that feels like. I know what it feels like. It's okay to be you. And so I mean, I weep when I hear it, because I remember sitting there trying to figure out what we were going to do. And to just know that, like, my friend had so much turmoil, while I'm on the other end doing the same thing, only I wasn't brave enough to lock my hair. Also, I'm not as dedicated. Okay, I would shave my head. I just, I think that that's our point now. That's our job, is to recount those stories and to make sure that the ones that come behind us know what we've already experienced, and that it's okay. Whether you want to shave your head, or you want to grow it out, or you want a beard or you don't, as long as you don't have beard hair falling on your patient's face, I think it's fine. Go for it.
Please.
That's right. Sean.
No, I gotta say, I love your guys' points. I absolutely love it because I myself, when I started in data analytics, I was army of one. I had no one to help me, no one to show me the ropes. I was trying to figure out what the C-suite wanted of me. I was making a lot of assumptions. Unfortunately, I saw a lot of what you guys are talking about. When interviews would happen, they'd be like, just, there was no good reason why we wouldn't go with that candidate. But I also would like, I've been on really good ones too, where I've seen people be like, you know what, that person's really smart. Um, we got to give them a chance. And I was one of those people. They were like, we just took a chance on you. So there are good leaders that I think can and do look at, we're hiring to fill a skill set, right? We want the best person that will fill that skill set. And I'm sorry, but I have not seen a survey yet in healthcare that asks, how was your healthcare provider dressed? How did they look? And so if it's not important to these governing bodies, I'm back with Dr. Wellaway. Then who is it important to? Because in my idea, as this is my Aaron's own perception, but if you're brilliant, and I've worked with most of the brilliant docs on this call, if I've worked with these brilliant docs, and you come in and you save my life or you make me better, I don't care what your hair looks like. I don't care what you're wearing into my room. Hopefully you haven't had any alcohol before you come in. But other than that, dress doesn't matter to me. If you know your stuff and you're smart and you're intelligent and you can communicate to me what my problem is and what I need to do to get better, that's all that matters to me as a patient.
Dr. J, what are you thinking?
Yeah. This conversation, I've just loved listening to it. And I just see this whole spectrum of it. It's made me reflect on my journey in medicine. And I just remember that almost being conditioned starting in undergrad, and being pre-med and counselors, advisors, not having been in medicine themselves, but trying to give us the best advice that they could about how to dress, how to do the interviews, and how to, look the part. And that it was going to be a black suit, and it was going to be heeled, and it was going to be, and that you had to have the uniform, you had to do it. And medicine is a whole different culture. And the people that you were going to be with and talking this different language. And there was almost this part about having to assimilate into this to fit in with everybody else, because in the med school class that I had of 240 some odd people, there were maybe 12, maybe Black or African descent medical students. So we were a very, very small portion. And then going through this whole experience, and kind of figuring out how to make it through, because there wasn't a lot of help. And then I think about, being a resident, and you are still in this hierarchy. You're not a medical student anymore, but you are still under this attending, and that you still don't always have a lot of power or control. And I remember patients saying, like, I don't want a Black doctor, but the whole team was Black. So like, what are we going to do? Or somebody saying, well, I want to talk to the senior resident. And I'm like, that's me. I'm the 5th year chief resident. Like, okay, well, let me turn around and let me talk to you, okay, so what can I do? And so bringing up all of those feelings. And then finally, even when you were applying for that first job or those other career things, and being concerned about how you're going to be perceived, and that you don't look the part, or that you're not professional, and having people say that, which can be very hurtful, because you spent all this time and all these years to get to this point, and you still are worried about how you're going to be accepted. So the constant self-doubt, imposter syndrome, do I belong here? Do I really fit in? And I just wonder that for all these years, from undergrad all the way up till, trying to be an attending, how much bandwidth gets spent on dealing with these other things that other people don't even have to deal with? They can just learn to the material. They can just show up on their rounds, show up and teach their students, and they don't have this other level of things that they've got to be thinking about when they enter the room, when they start talking. That I know that ever since I was little, when I would answer the phone or I do things and people hear me and then they see me and they're like, are you Dr. Jordan? Wait, okay, And so they're in their head, they're like, wait a minute, that you don't match, your audio doesn't match your video. Like what's going on here? And then I think about what Aaron said about the pandemic and changing and, how things are perceived and being in telemedicine. And I can definitely say that for me, having gone from inpatient, where I was a consultant, and you've got all these different stakeholders and everybody wants something from you when you're a consultant in the hospital, and they got their agenda and they want you to help get them what they want. And that pressure and that perception, and you've only got 15 seconds, to make that impression with these families when they're going through one of the worst experiences of their life, and they're going to decide yes or no, like, are they going to work with you or not? So like making that therapeutic alliance, like you don't get a lot of time, and that pressure from that to now where I work in telehealth and I can just focus on the patients. And, I don't have all these other stakeholders. It's just me and the patient, and they can be present because a lot of them are in their home, which is their sacred space. I'm in my home. And, we don't have all of this extra stuff. We just have a conversation and we have the appointment. And it has taken off this level of stress. Now, the patients in their surveys, if it says, my doctor was professional with me, they treated me with respect, so far, it could always happen that somebody says, oh no, I didn't like her top that day, but I didn't like, she needed a haircut, but I think that they actually get a chance now to see me, and I get a chance to see them. And so it has taken off a lot of that stress. And you were talking earlier about burnout. And I think this has helped me not have burnout because I can just work on just doing my job. I just have to do my job. I just need to show up. I can just do that. And I also it made me think about when people were having these go back to work mandates from their jobs, and they were asking and surveying who's saying, yes, let's go back to work, and who was saying, nah, I'm gonna take it at home. The people who are really, really eager to go back to work were usually people that were not Black or brown. A lot of Black and brown people were like, nah, I'm gonna stay remote. I don't want to deal with the microaggressions. I don't want to deal with the comments. I don't want to have all these extra things that I got to deal with. I can just do my job. And they were the ones that were pushing back, saying, well, if I can't stay at home, then I'm going to go find something else. And so I think, thinking about the COVID, the pandemic, how that shaped in medicine, now for some of us, we found that like, wow, I can still practice. I actually can still be a doctor. I can still do this work, but I don't have all those other things that used to the bandwidth it used to take every day that was just so exhausting that I didn't even realize it because it's been decades in my journey of medicine of just dealing with it. And I just thought that's how it was going to be. But being in telehealth has shown me that there is actually a different way that I don't have to worry about that.
I think that's so powerful. And we saw a lot of that, to your point, during COVID, and people even within medicine and a lot outside of medicine that were able to work from home and have these virtual meetings. I saw some studies looking at whether the camera was on or not, and found that people were more likely to speak up, more likely to contribute if they didn't have their camera on. Because again, it's not that people are judging me. How does she look? How does she speak? And, it's just the work that I'm doing. You're still hearing voices. I think some were even typing. But it's really interesting. It says a lot. And to the point about, DEI and the importance of these things moving out of medicine and other places, one thing that we have seen in our in our world as far as medicine and medical training is throughout COVID, moving to virtual interviews because we couldn't be one-on-one in person. But a lot of the different specialties have continued that, even though now things have come down and people can come in person. Many of them have said, no, we want to keep it this way for a few reasons. One, it's cheaper, right? The amount of money that we had to spend to travel around the country to go from interview to interview, if you could save that money and do interviews in your living room, we did see a lot more people applying to a lot more programs because they had the finances to do that. The other thing is there was the less bias. That was the other thing is, well, some people live close to the hospital, so things have opened up. Maybe they can come in, and many organizations and specialties said no, because we might think of that person more favorably because we've seen them, we got to interact with them, whereas this other person we're just seeing on the screen. That doesn't make them less of a qualified candidate. And I really applaud programs that have done that. I know where I am, we've really looked at how can we make it as objective as possible, asking people the same questions and hearing their responses. Again, trying more to compare apples to apples, which I think is very important. Another point that has been brought up a lot is this kind of being able to be a chameleon. When I'm in this room, I sound like this. When I'm in this room, I sound like that. And I think, especially for minorities, it's something that happens all day, every day. That's part of our life, and I do think it is cultural competency. And I remember sitting through classes around cultural competency, and it's really important to understand that these folks in general may not want you to tell the patient their diagnosis because grandpa's not supposed to know or worry about that. You just tell the daughter and the son, and then they will tell the rest of the family, and they will just support grandpa through that. That's really important to know. And so having conversations about who are you, what's important to you is really, really important. And I think as the outsiders who minorities tend to feel like, we're kind of used to that already. I remember thinking, well, duh, like, wouldn't you ask these questions ahead of time? I think when we're talking about race and ethnicity, it feels a different way. I know, I think Dr. Andrews talked about a lot of this being politicized, but I think the same thing happens when someone walks into a patient's room and there's a basketball game on the TV. And it's like, oh, so do you think Duke's going to win? The next room you go into with the grandmother who's watching telenovelas, you're not going to ask her if Duke is going to win this game. That it's the same thing. And I think, again, good practitioners, good physicians, but good people do that. You read the room, you understand who you're talking to, and you work to make them feel comfortable. In this new area, also not losing sight of yourself, which I think that is actually the new component.
I think you brought up a point about, I think it was Susan that talked about some of the dermatology colleagues wanting to do away with a lot of DEI programs. I don't know if you guys have heard about, I believe it's the former dean of the SOM at UPenn and a state senator who are trying to do away with DEI across the board in medical schools. And the reason I think one of their reasons, and this is it's not a direct quote, but was that he said something to the effect of medical students are no longer picking up scalpels and learning how to practice medicine, but instead learning about social constructs and homelessness. And I said to my husband out loud, I was like, is this full serious? Like, it isn't that what you should learn? And if you're going to treat patients, I think that's the biggest component of this, and that is to learn that we are all different people. We all come from different areas. There are different things that I experienced culturally that Carol may not have experienced, that she experienced, that Dr. J didn't experience, and so forth. And we may not understand them from A to Z, but to have a general understanding of why it is we don't see eye to eye on this particular subject is what helps me to connect and have that emotional intelligence that Melanie was alluding to. And so I think that this comes back to not just making sure that the individual is comfortable in their skin, but also understanding that it's okay for the person to my left and to my right to be comfortable in theirs, and it not affect the way that I move forward in life or the way that I present myself. We all have friends who practice different religions and different um, relationship practices and schooling practices and things of that nature, and it doesn't change the way that we interact with each other as friends. So why would it change the way that we interact with our patients? I think it just comes down to being mindful that society is ever changing and diversity is ever happening, and the people who want to stop diversity are the very people that I feel like are uncomfortable in their skin. You're uncomfortable with the way that you're presented to the rest of the world. So rather than be able to see the diversity that's around you, if I can stifle that, then I don't have to be uncomfortable with the fact that you're different from me, if that makes sense. And that's across the board. That's not a race thing. That's just anybody who thinks that having diversity in any space is a detriment. Like this world, if we look around, Black and brown people, white people, we are no longer the majority. I think the Latino population makes up like 53% of the entire state population in Texas. I told my son the other day, I was like, you need to learn Spanish. He was like, why? We don't live in Mexico. I was like, kinda. I don't expect you to hold a whole conversation, but you need to be aware. Like, if Abuelita comes in and she starts asking you questions, like, at least be able to say, slow down, ma'am. I don't speak that much Spanish. Let me find somebody who does. Just being culturally aware of what's happening around you, I think, is just the biggest thing, the lesson from all of this. If we are more comfortable with the fact that everyone is different, it doesn't make it that scary. We always say that, we teach our kids to love everybody. So then why can't we do it as adults and just let people be people? Except when they be people and too hard.
But I think that brings up, but I think you bring up a good point about we've got this thing in medicine about, about being different or looking like the doctor, whatever that means. And we still never, I don't know what that looking like, looking like the doctor in the hospital, looking like the doctor outside of the hospital. But honestly, we need to be looking and representing the communities that we serve.
Mm-hmm.
That's what we need to be doing. Yes. If we want to have these therapeutic alliances, if we want to connect with people, again, we're already in this medical culture. So all of us, we know how to talk. We know what to do in the hospital, in the clinics, remote work, whatever, data analytics, like we know that, but we've got to make a connection to who aren't part of this culture, who aren't part of this world. Because if we don't talk to them, if we can't break down all of our expertise, all of our knowledge, and they don't, and we can't do it in a way that translates to them, then we've missed the mark. And we're not going to be changing outcomes. We're not going to be changing people's livelihoods. We're not going to be breaking generational cycles because they're going to say, like, yeah, they look like me, but they couldn't relate to me. Or because we make medicine, healthcare so like we all look the same, then it's going to, those people who are coming up behind us, you can't be what you can't see. So then they're going to be, where is a space for me in medicine? Because nobody looks for me because we selected out the people who actually come from those communities. And so we're never going to get better in all these outcomes that we want to see and all these metrics and all these things that we're trying to do. If we don't get people from those communities and we don't make them feel comfortable, they're not going to stay. And we're not going to be getting any better. We're not going to move forward.
I'm really curious to understand and hear from you guys about this. I've been thinking about this one. When your patient ratio is high and you have a lot of patients that you have to take care of, how do you take the time to become that chameleon, get to know that patient, and connect when you know you got to go room to room? Because I've been on the other side where the doctor comes in, tells me what's going on, and they're out. So there's really not that connection. I've had that. So I'm curious to hear from you guys about how do you make sure that's number one priority when you're doing those roundings or you're meeting with these patients and you've got another one right behind you? How do you keep that in the forefront of your mind to make those connections?
So I'm going to make a comment on that because I have a clinic. People wait for me 45 minutes to an hour. And the first thing I walk into the room, I say, thank you for being patient. and I'm going to take a seat and we're going to have a conversation. By then, hopefully, I know your history, a decent part of your history. But to me, by acknowledging and thanking you for being patient and waiting on me, that is the signal to my patient. I'm going to provide you just as much time as I provided the last patient. We are going to spend as much time as it takes for me to address your issues or whatever it is. And I am aware that they're waiting on me because I have a bunch of patients, but more importantly, they're waiting because I am giving each and every one of them the time they deserve. I don't put myself, the only clock I am on is what the patient. So that's how I've handled that in my practice.
That's awesome. Yeah, that's perfect.
And people can feel that, right? Like they're they're not coming back. If they had to wait, you walk in, hey, this is what I see from your chart. Okay, we'll schedule surgery or 2 weeks from now. Have a good day. Then it's like, whoa, I waited all this time. I didn't get to explain what was going on. I don't understand the plan. Am I supposed to be NPO? Like all these questions. And they feel like they have to go home and call back with a long list of questions that they wanted to have addressed during the visit. And I think that's so important to be able to provide that care. I mean, the construct that is medicine and the way that we practice and the way that we get paid, I feel like makes it really, really hard to provide the type of care that we know each patient deserves. And so when you're trying to do that, and maybe that'll be another podcast on what happens outside of medicine when you are doing this day in and day out, because that means you're getting home later. That means you're missing kids' events. You know, all types of other things happen with the current construct. But people can feel that. And regardless, again, as you were saying, Erin, of who you are or what you look like, if you feel like I feel like you're listening to me, you're understanding me, you're explaining things in a way that makes sense to me, and I can trust you, I'm coming back. And I'm going to tell my whole family, look, you're going to have to wait, but it's worth the wait. And people do that, which is a testament to the type of care you're providing.
Yeah, I think you're exactly right, because I've had both. I've had providers that come in and they're out the door before the door even like closes from the first time they came in. But I've had the other ones who are active listeners, and that's what, to me, that's what makes me go back to them. So I'm 100% agree with you, and that's really, I think I agree that that's really what patients are looking for. They want somebody to listen to them and make them feel better about what they're going through and spending that time, whether it's 5 minutes or 15 minutes, but just feeling like you're important as a patient to them. So
this concept in my practice is what I call some for you, some for me. So every patient I see, even if I know why you're there, I always start with an open-ended, what brings you in? And then at the end of the visit, any questions? And so what that means is some for you is this is your time to speak. And I, as your provider, am going to make sure that you have that time, even if it's a quick visit. Some people, we both know what's going on. It's a 5-minute visit, but it's still the same. How are you? What's going on since I saw you last? So that's some for you. And then my part is some for me, where I tell you, okay, this is what's going on. This is what we're going to do. And then I always end it with some for you. Any questions? And so even if it's 5 minutes, the fact that you got to voice, you got to articulate, you got to share, and so did I, it makes it an equal visit. So yeah, that's something that I think has really helped me to at least walk away from even really fast exchanges feeling like I think they felt heard and I heard them.
yeah, I would agree with that 100%. I would even take one step further and say making eye contact, right? Because I've had it too where they'll be like, so what brings you in today?
Mm-hmm.
And they never look at me. And I'm like, oh, they really don't care what really brought me in. They just want to get me out of here. Here's your medicine and go pick it up. But I feel like, yeah, you're 100% right. If you're asking the open-ended questions and you're giving me an opportunity to talk and you're looking at me and making eye contact, like, to me, we've made that connection now. Like, I know you're here to help me feel better, but awesome.
I mean, we're highlighting these things, because this is also the other part of professionalism, right? I think somebody brought up the HCAP questions, and I found it interesting that a lot of and these questionnaires are sort of given to patients to kind of assess performance, and the professionalism questions that patients are asked are really character questions. Were they courteous? Were they respectful? Did they listen to you? These kinds of things. And so, aside from how we look and how we present physically, that this character in terms of that professionalism is a part of it. Going back to med school, that was we had a course called Practice of Medicine, and that was part of the point. Is in this art of medicine, part of being a professional is this character that you exude. And it was something that was really it left an impression on all of us. Like, this is your duty as a physician to maintain this level of ethics, morality as part of your professional character. And yeah, so I think, weighing these things and understanding these things is definitely all part of it.
So I'd be curious to know, like, we go back all the way to where we started, and we said, do we think burnout, you know, could contribute to some of these issues that we see with the questions around professionalism? So I feel like, and I'm curious to hear what you guys think too, but I feel like I know COVID definitely put a heavy strain on physicians and the clinicians in the hospitals, and did cause a lot of the people to question, like, do I want to continue to do this after COVID? So is that enough? And other external variables that play into this, is that enough to cause that burnout to where you may have got taught and may have got seared into your brain that this is what is expected of you as a physician, but after all these things that have happened, do you think that maybe that's been pushed to the side as not as critical as it once was?
That is a very interesting question. That going back to that period of time where we were learning what professional character is and what our duty, right? We were taught that this is not just a job. That, for lack of a better word, indoctrination is really deep in the core of a lot of us. And I think what happens when COVID hits and all these other things hit is a lot of physicians are sort of confronted with this core of them that says, I'm supposed to be this person. I cannot give up. I cannot falter. I cannot. And so I don't think, at least from my understanding of it, I think people didn't put that to the wayside. I think it only compounded what people were feeling, because you're feeling the weight of COVID. This is affecting society, but then you have this voice in you that's been there since med school, but I'm supposed to be. And now how do you rectify this? So I think it compounded the pressure.
So-
And there were periods, right? There was the period of the doctors are the heroes. They're going to get us through this. And then what's wrong with these crazy doctors? Why are they talking about these masks? I'm ready to go back to Six Flags. Like there was a time where there was a shift, and we were still expected to go into our practices and provide that same level of care to people who were literally spitting and saying, I don't believe in COVID, as we are saying, I'm going to have to intubate you. You're not going to be able to breathe on your own. I really think you need this medicine. This is the best we have right now. I'm not taking any of those. I mean, it was a tough time. And it's not to say that these things don't happen regularly, but COVID was a whole different beast.
Yeah, I think Susan was probably said it way more eloquently than I could have. I think that COVID definitely compounded those internal struggles with being that persona that we built while we were in med school. We didn't have I worked for a larger corporation, so I felt like the corporate pressure wasn't there. It was more self-induced. And then societal pressures, I think, I don't know, to give you we went from coming home and seeing our families to coding patients in the hallway. You come outside and you see signs that say, doctors are our heroes. And then I go inside and I'm coding somebody in the lobby and the person next to them sighs and says that we're not moving fast enough to take care of them. Or, like Carol said, people will spit or they follow you to your car and tell you you're not doing enough or, so things like that. And I think that, society puts an unnecessary amount of pressure on physicians to fit into a box. And some of it is self-induced on our part because we were taught that that's what we needed to be. But I think that people have to realize that we are people. We are people who are constantly growing and learning and experiencing and, to speak on behalf of some of my colleagues, some of the things that we've seen, or, I won't even use them. Some of the things that I've seen in the last 4 years are things that I pray that the people coming behind us never have to experience. And, does it shape us as professionals? Absolutely. I can only be spit on so many times before I start to retaliate. And unfortunately, the person that does the spitting is the person that walks away, but every person behind them gets to catch that attitude that comes out. And so, in my 10 plus years in doing this, I've learned to put those feelings aside. But unfortunately, somebody catches the brunt of what that feels like. And right now it's po baby. Because you got to offload it somewhere, and I just think that, as society, if we are allowed to be ourselves and kind of respond in situations so that we feel protected, or we're allowed to take that time and say, I've had enough, let me take a moment, then I think that we'll all be better for it, the physician and the patient alike.
Yeah, I think that's amazing. Thank you so much for sharing those stories. That, I think it's very important that mental health of the providers is very important, as much as you guys do, and as amount of the work that you put in and the passion that you guys have. And I think that's what I kind of have heard, is that this indoctrination you're speaking of about your duty as a provider, you guys carry that so heavily, and you don't drop that. You keep that always, at the core, like you had mentioned. And that alone, I know, is a lot of burden. And I think, and I hope that we do see for the providers something in place to help for that mental health awareness and keeping you guys, give the support that you need. And I love what you mentioned about making sure those that are coming behind you have the support from these veterans like yourselves, and that knowledge sharing. So again, thank you all for sharing your stories. Amazing stuff. So thanks.
And I think with that, we will call it a wrap. So thank you all very much for your thoughts, for sharing personal details, and being so vulnerable today on Doctor's Day. For those of you who are watching, we are filming this on Doctor's Day. So I think this is a great, I know Dr. Jordan mentioned this is a great discussion for Doctor's Day. So appreciate everyone's time. Thank you all for watching. Again, if you have ideas about things that you'd like to hear us talk about, please drop that on our social media. You can find us on LinkedIn, Instagram, Facebook, and our YouTube channel, where you'll be able to find this podcast as well. So thank you for listening. Thank you for watching. And thanks to the amazing Advantage HCS team once again. We'll see you next time. Bye-bye.
Bye.